Picture this. You finally made it on vacation. You survived the chaos of the airport security. You powered through the airplane chicken. And after 8 hours crammed into economy, you stand a stretch. But instead of just stiff legs, you notice one calf is swollen, sore, and a little warm. You shrug it off. It's probably just too much Netflix at 30,000 feet. Fast forward a couple of days. You're lying on the beach, pina colada in hand, when suddenly you can't catch your breath. Your chest feels tight, like you pulled a muscle you didn't even know you had. The next thing you know, you're in the ER, and the doctor tells you you've had a pulmonary embolism, a blood clot that started in your leg and broke off into your lungs. That's the scary part about clots. One moment you're living your best vacation life, the next you're hooked up to oxygen with monitors beeping next to you. Today, on Not Another Medical Podcast, we're talking about clots, when they're normal and life-saving, and when they're dangerous. We'll cover deep vein thrombosis, pulmonary embolism, the red flags you shouldn't ignore, and what you can actually do to prevent them. Because let's face it, clot happens, and knowing the signs just may save your life.
I'm Josh Levitz, an internal medicine physician.
I'm James Jung, a general surgeon.
And I'm Brodie Nolan, an emergency doctor. And this is Not Another Medical Podcast. The opinions expressed in this podcast are those of the host and guests, do not reflect the official policies or positions of any affiliated institutions or organizations. This podcast is for informational, educational, and entertainment purposes only, and it is not intended to provide medical advice, diagnosis, or treatment. Listeners should consult their own healthcare professionals for any medical concerns.
What's up?
How is everyone?
Hello. Hey, Josh.
We haven't done this.
Yeah, it's been a long time, it feels like.
Yeah, we've been on an off schedule there, guys.
Maybe we should start off by saying to the listeners, if you're avid listeners, we apologize that there was a little hiatus in our scheduled release.
The weeks between incredibly October 3rd and 17th, somehow we missed dropping an episode. So now that this episode, though, is being recorded months later,
yes,
we still apologize for the inconvenience that may or may not.
Listen, I heard from some I don't think you're supposed to timestamp podcasts. I think they're just supposed to be like forever. So now that we're
time fluid.
Yeah, this one is not. Yeah. Although that could have been 2023 or 2029. It could have been any of those.
Back to the Future action.
There's some sort of mishaps that happen at some point in our timeline. And we just took a little bit of hiatus. And we recouped, and
there was hold on a second. Hold on, there were no mishaps. We were doctoring, we were parenting.
James, you're making some trouble with the band.
We made a promise. Well, nobody made a promise, but we we have a commitment that we wanted to uphold.
You're thinking of your wedding vows, James.
Yeah, that's another story.
Oh man.
Oh, that took a turn.
No. We're very happy.
Well, we're glad to be back. Apologize for any gap that may or may not have ever been noticed, but we're here. So
Brodie, tell us about life. You have the most interesting life right now.
Yeah.
Trying
I don't want to dive into too many things, but I will say today was kind of a weird day. I was just myself, one of my daughters this afternoon anyways. My other one is off with her in-laws, or my in-laws' parents, I guess. Or my wife's parents. Anyways, I had my daughter today and we were hanging out after school and the natural conversation comes up of like killing time. Like, what do you want to do? And she said she wanted to get her nails done. So I was like, great. So I went for a lovely
first time
daddy-daughter pedicure.
Show us your nails.
They're the same. But it was wonderful. Honestly, we went out. I got like a sweet foot massage scrub. She got her nails all did. Went out for dinner afterwards. Had some pizza. She had some carbonara. It was honestly like a really great time.
That's solid parenting.
That's like, circa 2008 Drake fancy.
Yeah, exactly. Little take care action.
That's fantastic. Was it?
That's really.
Was it their ideas?
Yeah, it was all that was the greatest thing. We kind of show up because I have zero care actual stake in what color she gets. So then like you walk in, there's like a wall of color. I should also say
There's like
I've
low
never walked
expectations.
into a nail place for a pedicure or manicure before. So like I was following her lead, and like she's 5 years old. She's like, oh yeah, like I'll
That's
go in, like
amazing.
I'll choose my color and then sit down. Like sat down beside her, and then she's like, aren't you gonna get your nails done? I was like, sure.
See,
Yeah,
Brodie, you think you're teaching her, but she's really teaching you.
It
Yeah.
was honestly the greatest like self-care advice.
It's
It was a
amazing.
little like
I'm glad that
5-year-old, like,
you
what a great
picked out
nugget.
your,
I loved it.
Yeah.
It was great.
and I'm
Yeah.
glad that you picked out your true color, Barbie pink. You know, it really
You
fits
saw,
well with you.
right?
Yeah.
Thank you. Yeah,
I
yeah. I'm
was
not going to
gonna
show my
make- I was
toes
gonna-
on camera because like this isn't my OnlyFans page, but you know,
Although that is a good
amazing.
page.
only toes. Yeah.
Only toes. Right.
What about you guys?
I'm going to Vegas tomorrow.
Oh, really?
dang.
Oh,
Yeah,
wow.
is that cool? That's pretty cool.
Did you get your nails done for
Wow.
Vegas?
I will get them done in Vegas. Heck yeah! After that story, yeah.
What, can
Yeah.
we? What's that for? For work?
There's a innovation in medicine conference. It's going to be super
Oh, that's
cool.
cool.
And
That's
some
great.
fun speakers, cool stuff. Get away for a few days.
That's awesome.
That's great. Next week, I'm actually going to Singapore for.
Of course,
10
of
days.
course.
Wow. Okay.
I
there it
couldn't.
is.
I couldn't have one. I couldn't have one. To find
Yeah,
James.
Vegas
travel
is
to-
cool, I guess.
Always has to one up.
I guess. But you know,
I'm not even going to Vegas. I was just lying to be cool, and it doesn't even matter anymore.
You set me up.
We
But,
don't do
you
this
know,
intentionally, but James is literally always traveling. Josh, I go down the street for my nails. Josh gets out of the country. James like, boom, I'm out of the continent, guys. Peace.
Yeah. I'm going to
Yeah.
the moon.
All right, so what are you
if
going to
want.
Singapore for?
I'm doing a keynote speak. You know, no big deal. But you know, at one of their hospitals, and you know, they have stuff, you know, set up for me. So I'm pretty happy with that. But I do have a segue.
Mm-hmm. Besides being
Which-
very humble, I will say. Not that humble
Oh,
is
yeah,
being a
yeah.
segue, but I know you're holding back, and that's pretty cool. So kudos to you, man. That's awesome.
Oh, thank you,
That's awesome.
thank you.
I also
Maybe
might
when I
suggest
come back,
you
from
go
it.
for a sweet pedicure.
Yes.
Well, you got to have some
Prep
good
for
ones
your
there.
keynote speak.
Yeah.
Wait. Hold on. I think I see where your segue is going. Do it, buddy.
I think I
Uh-huh.
do too.
Yeah,
I
yeah,
do too.
yeah.
Yeah.
So
Yeah.
this flight that I'm taking.
Such nerds.
Yes. Nailed it.
So I've heard that this may be the longest flight that's available that is nonstop flight. It is 19 hours from JFK
Oh,
to Singapore.
Is there like a mid-air
Whoa.
refuel in it? Like that is crazy to me that you can run an airplane for 19 hours on one tank.
I'm not an expert in aviation, but
Yeah.
that sounds
Are you
like,
like,
a,
paragliding through some of this? Like
Yeah,
your last
just
3 hours?
just the last like
on a
3
kite?
hours. We just get on a little like parachute. And it's just
I don't
Just
think I
jump.
could do it. I would
Man,
lose
that is-
it. Like 10 hours in, I'm out. I'm running up and down
Yeah.
the aisles.
I wanted to ask you guys, and you guys all know where this segue is going to, but when I ask you like long, let's say 10 plus hours flight, what do you guys bring? Or are there things that you do knowing the risks that are associated with long-term flights?
Like, are we,
Humongous risks, but is there stuff that you think about, you do?
this is,
So wait, I
this
just
is
wanna
very-
make it
This is an
clear.
evasive segue here.
yeah. Hold on. James,
No,
you
I
had
mean,
the segue. Now
I
you-
know.
you segued the segue.
Well,
Or-
compression stockings. Why would one bring compression stockings to long-term flights? I think that's what we're talking about here. So, Brodie, you brought this topic to us. I think this is such an important topic that a lot of listeners wonder about. You are one of the first people to see patients who present with this. So, love to get your thought on this.
The reason why I chose this is the whole developing a blood clot while traveling is one of probably the more common risks that we know. And we'll talk about risks later on. But the other thing that I find both fascinating, but also a little bit devastating about blood clots, and again, we're really talking about deep vein thrombosis and pulmonary embolism. We'll talk about that in a minute. But I think these are also things that can be hard to diagnose in the emergency department and can be hard to separate from other people presenting with things like chest pain or shortness of breath. And unfortunately, every couple of years, there is someone who is college-age student who presents to the emerge with chest pain or shortness of breath, gets seen, gets worked up, gets sent home, and then unfortunately dies, right? And or like they come back a second or third time. And it's just something that I think because of that, because of the risk of if it's missed and it's not caught early, and you're not given those interventions, it really is a life-threatening diagnosis. But doesn't always present in showing up that you're super sick with it. And that's one thing that I find also fascinating about medicine, but really the variety of which how patients with the same disease can present, right? They can be really sick and not sick. So that's what I found was really interesting about it. Hopefully that's also what the listeners will find interesting about it. I think it brings up a good just general concept that most people with most diseases do really, really well. They're diagnosed, and honestly, even some of the ones that aren't diagnosed do just fine or don't even know they have an issue and do fine. But we talk about the outliers because those are the ones we really want to prevent. And this is a perfect topic to get into that. Yeah. So I thought maybe I'd start off with talking about what is a blood clot. And I think the important thing to remember is, again, developing a blood clot or your blood clotting is a totally normal and life-saving process, right? Like you cut yourself shaving, you want to develop a clot so you don't bleed out from having like nicked your leg or your chin, right? Like these are things that are really good that the body does most of the time.
Yeah.
And one of the ways to think about like what a clot is kind of thinking it as like your like emergency road repair crew, right? So you cut yourself and then the crew goes out and it throws, what would be platelets and clotting factors on it, but really you are trying to stop whatever bleeding that you have by doing that. And that's helpful when you're sealing a wound, but it's harmful if you're just randomly putting a clot inside of blood vessels.
Right. So kind of the complete contrary to blood clot is patients who have hemophilia. It's inability to produce clot. And because of that, if you get cut while shaving or if you get little lacerations, difficulty to stop the bleeding. The blood clot is a natural thing that you need to help stop the bleed, and it's very essential, like Brodie said. So tell us a little bit about what is a normal and abnormal in terms of deep vein thrombosis and pulmonary embolism.
Depending on where you clot in the body, it's all cause different things. If you have a blood clot in your brain, it's a stroke. A blood clot in your arteries of your heart, it's a heart attack. And maybe jumping back to this patching potholes theory, the normal clotting process is there's some sort of injury to the blood vessel that you are repairing so you're not bleeding out, and that's a normal process. But when you have abnormal clotting, it's kind of the equivalent of like a road repair crew throwing a bunch of asphalt in the middle of the highway, right? Everyone's going to slow down. You're going to have traffic jams and crash into each other. That's exactly what happens within the blood vessel system as well. And that's what causes.
Otherwise known as Toronto, Ontario, Canada. Yeah.
So if you have Toronto in your legs, you have. Yeah. So what we're talking about today are really two entities of where you develop these blood clots. And so one is called a deep vein thrombosis, or a DVT. And this is when you form a blood clot in the deep veins of your extremities. Most of the time we're talking about your leg. So this is a blood clot in the back of the knee or the back of the thigh. Some people can get it in their arms, but for the most part, most of the time we're talking about deep vein thrombosis. We're really talking about in the legs. And then the other one that we're talking about is something called a pulmonary embolism, or a PE. And most of the time, I would say, when people develop a PE, it's because there's been a blood clot in the leg. They have a DVT, and it gets dislodged. It travels through the venous system up into the heart, and then this blood clot launches off and goes to the lungs, and that's where it gets stuck, because now all of a sudden the blood vessels, the arteries, are going to get smaller and smaller to that level. So that's where they get stuck there. And that's a PE, or pulmonary embolism.
So it's a bit of a two-step process, right? So there's a blood clot that has developed mostly in dependent areas of the body where blood stays more static, or blood doesn't move too much, and then it is more, the environment is more conducive to developing clots. And then eventually this venous flow come back to the heart, and then where the blood is received, and first place it goes to is the lungs, or the blood vessels in the lungs, and that's when it becomes a pulmonary embolism. So I think it brings up why I talked about long flight as a segue in a very unsuccessful manner. But tell us about what these risk factors are that people develop DVT. and, pathophysiologically why this happens.
Yeah. That's good. And
James, thanks for taking ownership of your, what do we call this? Miscue. We'll call it a miscue.
Yeah.
You owned it. I appreciate that.
Yeah.
And I will allow us to move on. And I'll consider keeping that in for the editing.
I'm sorry for the 3 minutes that I wasted at the top of the show.
Yeah. Oh, we have so many more minutes to apologize to our listeners for wasting. And that was 3 minutes, man.
How many podcasts times how many minutes? Yeah.
So what I always find interesting about really the history of medicine, or just like, how you like have these like overachievers, like, yes, James, I know you're getting flown across the world for a keynote speaker and, yada, yada.
By the president of a country and just like,
but like,
whatever.
Man, there's just something about like those old school like clinicians from like the 1700s. It's a whole different
Usually
level. So,
from Eastern Europe. I feel like.
Yes. And all, yeah. So of that, Rudolf Virchow was a German physician and scientist, which among a bunch of things developed this mechanism that he proposed for how blood clots, essentially. And he came up with, as they did in the day, naming something after themselves. So came up with something called Virchow's triad. And this kind of really helps you think about what are your 3 main risk factors for developing blood clots. Besides that, again, for talking about kind of overachievers, he also came up with the theory that all cells arise from other pre-existing cells. He was the first person to recognize leukemia and also developed modern day autopsy techniques. So again, if you want to talk about someone who did a whole lot besides. So the 3 things in Virchow's triad for risk factors for developing blood clots are stasis. So James, you're talking about, these are things where you're not moving as well. So things like long flights, you're in bed rest, you're in a cast. And again, we think about the reason for that, right? So again, your heart does a really good job for pumping blood to where it needs to go, right? Through your arteries. But the thing gets down to your legs. Now it's fighting against gravity to get back to your heart. And it doesn't actually have enough momentum to do that on its own. So, your veins have these valves in it, and it's really dependent on you moving your muscles and moving around and walking or squeezing your legs and doing all those things that then compresses the veins, shoots it up your blood vessel a little bit, and then it can't go back down because there's valves in your veins. And that's why, people over time, if they develop leaking of their veins, might get swelling of their legs as well, for example. So anytime that you have prolonged periods that you're not moving your legs, stretching, walking, using those muscles in your legs, especially, again, that blood flow gets impaired. And you're at a higher risk, though, whenever things are just stagnant and not moving around as well, they have a higher risk for then developing a clot. So that's one of them. The second is vessel injury. And again, I don't think that's a surprise to any of the listeners. We talk about inflammation as being a big cause of all sorts of different conditions that we have. And it's very similar or kind of at like blood vessel level. So if you have surgery, and it doesn't have to just be surgery on your blood vessels themselves, but if you have surgery on the bones nearby, there's going to be swelling. If you have surgery in the general area, there's just going to be inflammation afterwards. All of those inflammatory markers and things that go around that, again, are going to be then relayed to the blood vessels nearby. And likewise, trauma, right? Surgery is really, I'd say, like precision or intentional trauma, right?
Yeah,
but,
controlled.
you get punched in the side of the face, like you get hit by a car and stabbed in the chest. Like, those are also potentially like, there will be swelling and inflammation, all those things. Yeah. So anytime there's an injury to the blood vessel or the vicinity of blood vessels, that's also a risk factor. And the last is something called hypercoagulability, which is really just kind of your innate body's disposition or likelihood of developing clots. And there's certain things that we know that are conditions that adjust the proteins in your body to make you more likely to form blood clots. These are things like cancer. Sometimes there are genetic conditions people are born with that make them more likely to develop blood clots. And the other one, and this is where, again, I kind of think about those examples, kind of college-age students, especially female that are presenting with chest pain or difficulty breathing, is birth control pills or oral contraceptives. Again, from a hormonal level, there seems to be something as well that's there that puts people at a higher risk for developing clots just being on a birth control pill. And so those are kind of the 3 main things that we think about.
What's really interesting is that all these risk factors and this whole Virchow's triad thing that you talked about, this was over 100 years ago, and we are still using it as the mainstay of how this happens, why this happens, and actually how to diagnose it in some cases to use some risks based on it. It's pretty wild that 100 plus years, nothing has changed. And he got it right back then, which is really impressive because that's when they were like using leeches and I don't know.
Just like he was just being able to figure out what a cell is, right? Like these are, do you guys know there's a bit of a segue fun story. I want to tell a story just briefly.
Yes.
To highlight all of that together. Yeah.
Story time
what
with
better way to
Brodie
tell a story
Nolan.
than to reference a story? So if I say the author, so I'll make it specific because I'm not great with names, but if I say the author Margaret Wise Brown, without looking at notes, do you guys know? Would you have known who that is if I mentioned that name?
No, not a chance.
Right.
No.
But if I asked
surprised.
two dads, do you know the story Goodnight Moon?
Yes, and I have it in French and English.
Ooh, overachiever. Okay.
Yeah.
So
yeah,
Margaret Wise
that's
Brown
how I roll.
was the author of Goodnight
Bonsoir.
Moon, which, again, something I have definitely read, probably combined at least 1,000 times for my kid.
Mhm.
It was also a revolutionary novel for the time.
Hey, Brodie, good night, mittens.
Good night, kittens.
Oh,
Anyways,
yeah.
the other
Gosh,
thing
that's
about the
kinda
book that was cool at the time, the whole and you start is that it's obviously a book about trying to put your kids to bed, which although has some like very questionable and somewhat terrifying diagrams and illustrations in it. From the beginning of the book to the end of the book actually gets darker, so that by the time you're on the last page, it's like clearly nighttime. Anyways, kudos to Margaret Wise Brown. Unfortunately, while she was she's actually on a book tour, I don't think, for Goodnight Moon, in France. She's 42 at the time, and she had a ruptured appendix. And went to hospital, as you do when you have a ruptured appendix, and had surgery for her ruptured appendix, as you do when you have a ruptured appendix. And according to her autobiography, a few days after she had the surgery, she was feeling so well, the doctor came in to check on her, doing the rounds, probably James asking if she's farted. And she did like a can motion, like kicking her leg in the air to show how great she was feeling, and immediately threw off a clot and collapsed and died. Now,
Is this real?
This is real. Like I'm not like I was doing research on like DVT-PE and trying to like this actually happened. It is bonkers. Yeah.
I believe you, and I have a question though. James, how many of your surgical patients do can kicks to show you how well they're doing?
Yeah. Oh, she was she's a very fascinating history. If you want to read more about like her and her life, yet as a surgeon, is there anything that you're giving patients all the time while they're in the hospital?
Yeah. What you're talking about, I mean, this is not for everybody who's undergoing surgery. For short surgery, and then you expect the patients to be mobile right immediately after, we don't give this. But for patients who's going to have a longer surgery, major surgery, who we expect to be bedridden for some period of time, then we would give some sort of pharmacologic blood thinner. But on top of that, more importantly, we also do physical maneuvers to help them not develop clots. So these are things like sequential compression stockings. So these are compression stockings that we slap onto the calf and kind of give massage in periodic motion so that the blood is flowing to the heart. I would love to have this in my own home.
It sounds great. You should also add on a little pedicure.
I have them
with
on
it
right
and
now.
Like,
yeah, exactly. And I'll do a little bit of can motion and show that I don't have a clot.
Yes, I didn't look into the details. One, to confirm, there's a bit of like some of the stories say that she died of the blood clot going to her brain, which would be very weird unless she had a hole in her heart. I'm not going to dive into that today. But I didn't dive into the medicine practices of the 1940s, whether or not DVT prophylaxis or getting, blood thinners routinely in hospital was part of that or not. But anyways,
And just to further that,
just
to further that from what James is saying, the reality is 90+% of patients in hospital are on blood thinners for prophylaxis these days. Most of my patients, unless you are remarkably mobile or you have a bleeding risk or you're going for a surgery or something like that, you're on blood thinners in hospital. It's usually a little injection just in the skin of the belly. And most of the time we forget to tell you that you're going to be on it. So if you're in hospital and you get a little injection in your skin in your belly, sorry, we didn't tell you why.
Yeah.
We've kind of talked about some treatment stuff, but why don't we get into, Brodie, what does this look like? You're seeing people in the emerge. You're the first line to diagnose these things. How are they presenting? What are you seeing?
Yeah.
What are you doing?
So I think of DVT and PE as presenting quite differently. DVT, again, this is a blood clot in the leg. Often you see things then that are a result of impaired blood flow to the leg. So your leg is going to be swollen because the blood's not going to be able to get out through your veins as well as it is. Because of that, it's often red because you have inflammation. Sometimes you can have a concurrent infection on top of it. And because you have swelling and redness, you will also probably have pain as a way for showing that. So usually, the classic sign for this is somebody coming in with a single leg that's red and swollen and tender. It's very rare, not impossible, very rare to get a blood clot in both of your legs at the same time. That's often usually more of like an infection or heart failure or other things might be going on. But that's usually
or someone who has ignored one side for long enough that it developed in the other side. Which
and then the pulmonary embolism one, those ones are really interesting because I'll be honest, the longer I practice, the more variety of patients presenting with complaints. So like your textbook answer would be someone who has chest pain. And normally we describe this as like a quote unquote pleuritic chest pain. So it's like a lung inflammation type of chest pain. So this is, it hurts. It's sharp when you take a deep breath in. It doesn't really, you can't really push on it. It doesn't feel better. It isn't necessarily a pain that gets worse when you walk around or move. But again, because you're impairing the flow of oxygen and delivery of oxygen to the rest of your body, people do often feel short of breath associated with that. In extreme cases, if it's a big enough clot or it's been going on long enough, people will present with extreme things like coughing up blood, or they've collapsed or have passed out, essentially, or feel like they're going to pass out when they kind of exert themselves. And so for me, I think what's really important is I think of these young, healthy people that are coming in that have a bit of a risk factor. And honestly, for like young women, it might be their only risk factor that they're on birth control. But when I hear the story that I go to the gym or do exercise 4 or 5 times a week or more, and now over the last week, I get short of breath going up a flight of stairs. I have a little like twinge of pain somewhere. Sometimes my chest, sometimes it's my shoulders or between my shoulder blades. That for me is like an immediate kind of red flag, especially if I see that some of their vital signs are off. Like their heart rate's higher than I would expect, or their oxygen level a little bit lower. But those are the kind of classic symptoms that we think about.
Yeah, and it's come up before in that the textbooks are great, but they are the average presentation. And they're what we have to teach medical students. But the reality is most people don't present like textbooks. So you have to have a really high index of suspicion for these kinds of things. And we'll probably talk a little bit more about, we over-test for these things. Over-test is not a bad thing in this case. We'll talk a little bit about that later because the textbook is not how people present.
Yeah, I've definitely had people that are like, this is my kidney stone, right? Like they have like pain around their back and it's a blood clot, right? Like, or they think it's an pneumonia, they're coughing up a bunch of stuff and it's a blood clot.
Now again, listeners, most of the time it's not a blood clot. Most of the time your pain that you don't think is a blood clot is not.
This is not the most top of our differential diagnosis. But just to add on some of the symptoms and signs that you've said, Brodie, the deep vein thrombosis, you talked about unilateral or one side leg swelling. And that's different from the other type of leg swelling we talked about in previous episodes, which is both sides leg swelling, pitting edema that we see from like heart failures, chronic kidney diseases, and things like that, versus this is swelling on the one side and the other side is completely fine. And unless there was a trauma associated, you have to kind of raise a suspicion of whether this could be deep vein thrombosis. In the hospital setting, I agree, these are the textbook kind of signs and symptoms, but if there's high tachycardia or high heart rate, that, sometimes even is enough to raise suspicion of whether there's a blood clot in this patient. So very atypical presentations, and we want to have high suspicions for these because the consequences could be devastating. So tell us about what we do to diagnose DVT and PE, Brodie and Josh.
And maybe this is going to get into diagnosis. Do you guys remember in med school that we were taught to measure the calves? Like we actually had a little tape measure that we wrapped around the calves to see if they were I remember part of the physical exam we learned. Yeah. And I remember I had to, if my brother's listening, sorry, Aaron. My brother was worried he had one of these after a long flight, and I was in med school. I didn't know what the hell I was doing. Yeah. And I measured his calves. And I don't think I've done it since
You
then.
diagnosed them? So you diagnosed them?
He was fine. Okay. Aaron, you were fine. Yeah.
Yeah.
Mm-hmm.
I think that's also maybe a good point too. I know we often focus a lot on symptoms, right? Like what patients are experiencing, but maybe James, just to get a little bit about what you're talking about, vital signs are vital, but those are also some of the signs that healthcare providers are looking for to raise their suspicion for some of these things. But I do think it's always worth, especially with chest pain or difficulty breathing, knowing that difference from your baseline is incredibly helpful for raising the concern factor. When you're like you don't understand, like I'm doing HIIT workouts 4 times a week and now like I can't carry a bag of groceries. But anyways, I digress. We want to talk about diagnosis. I think, James, kind of what you're asking. So how do we can do these things? I think the first thing, you have to at least suspect it clinically, because these aren't tests that we would routinely order when we're thinking about it. And there's two main tests that we would order. One that would be for DVT and one that's for PE. And then we have these decision rules that help us kind of guide based on their signs and their symptoms and their vital signs and risk factors, whether we need to even kind of go down that route. I won't really dive into that, but just to say that there's often a lot of times we're able to rule these things out based on your risk factors and vital signs and your history and things like that, without having to go down the point of doing some of these tests. But there's really a blood test, an ultrasound, and a CT scan. So this blood test that we use is something called a D-dimer, and your D-dimer is kind of a non-specific marker for blood clots. So your D-dimer is kind of like a yes-no thing, a positive-negative thing. So if your D-dimer is positive, it doesn't mean that you have a blood clot, but it means that we need to go on to do some of these other tests. If your D-dimer is negative, it means that you probably don't have a blood clot. We can save you the time for doing an ultrasound or the radiation of doing a CT scan. So there is a lot of utility in doing a D-dimer, I think, especially in the emergency department and with young patients where there is concern about exposure to radiation or time for patients for getting ultrasounds and things like that.
Yeah.
Josh.
And for everyone listening, a D-dimer, if you ever think you have a blood clot, a D-dimer is not something you just do, and it's not a yes or no. It's very dependent on the risk factors you have and other things. So it has to be decided, it has to be done in the right context. So don't just to say, don't go to your doctor and say, hey, I want a D-dimer because I think I might have a blood clot. It's more than just a yes or no.
Yeah. All great points, right? And the other thing that's hard about D-dimer is the older you get, the more likely that it is quote unquote positive. So there's inherent risks with a lot of that as well.
And you're more likely to have DVT PE when you're older in general.
And I was going to preempt James because usually here's where he makes a Josh's old joke.
I know.
But he's off his game tonight, so I win.
Now that I'm also getting older, I have less inclination to make those jokes.
Yeah. Should we do a D-dimer off to see who has the lowest D-dimer?
No, we should not.
You're
Sorry,
right.
that
We
was
shouldn't.
No, we definitely
that was
shouldn't.
a terrible idea. Thank you for being honest, Josh.
Oh man. Now we can measure calves to see who has the biggest calves. That I'm in for.
Oh,
there we go. Yeah.
Just give me 4 weeks of calf exercise.
There you go. Shit,
Calf
I was
only
the last
exercise.
day, guys.
Just calf.
I'll see you in 2
Nothing
months.
else, just calf.
This is funny to anyone else but us. It doesn't matter.
All right, so
the
diagnosis. So you said D-dimer, but what about imaging studies? What kind of imaging studies would you do?
So again, if your D-dimer is negative, that kind of allows us to stop there. We can kind of put that on pause. If your D-dimer is positive, or if you're just a high enough risk, then we'll go on and do some imaging studies. So the test to do if you're looking for a deep vein thrombosis is an ultrasound of the leg. And it's honestly a really simple test. They literally find your blood vessels and they squish it with the ultrasound.
Literally. Yeah.
Literally. And they say, yep, it's squishy. There's no clot in there. And then they move up a couple centimeters and squish it again. And the idea being, if you can squish the vein the whole way through, veins should be squishy, then there's no blood clot. If you can't squish it, there's something inside that's probably a blood clot.
Okay, so ultrasound, blood clot. So let's say there's blood clot. Then would you move on to do CT scan, or what's your kind of algorithm
for me?
in your mind?
The interesting thing is that the treatment for whether you have a blood clot in your leg or blood clot in your lung is the same. But my suspicion just for things I would warn that person about would be much higher if I see a blood clot in the heart. Because again, that's something that the blood clot in the leg on its own needs treatment, but isn't necessarily life-threatening on its own. But once it goes to the lungs, then you tend to be a lot more worried about their chance of death. So not everyone that has a positive ultrasound of their leg will go on to get a CT scan of their chest because it doesn't really impact your treatment.
Most people won't.
Yes, but people that are having respiratory symptoms or chest pain or abnormal vital signs might, only because, again, it just might affect some of that follow-up and the type of instructions and things I'd make them look for. So what that looks like then, or the other side is sometimes people actually don't have signs of a DVT, but there's enough risk factors that I'm worried about. They might have just spontaneously, developed a pulmonary embolism I'll go straight to a CT scan of their chest, for example.
Yeah.
If they have more respiratory symptoms,
Right.
they don't have any signs of a DVT.
Yep. And we are in resource-rich settings, the three of us. So we have access to all these things, very different in rural communities or places without the resources we have.
Yeah, so this algorithm that Brodie had mentioned, kind of from D-dimer to ultrasound to CT, I mean, unless there are specific, signs and symptoms that direct you to a CT scan first, that could differ in various settings. Like for us in surgery, D-dimer is not reliable like this. So we tend to go straight to CT scan if there are signs like high heart rate and shortness of breath or difficulty weaning oxygen off. So we may not necessarily do D-dimer first and then ultrasound and then to CT scan. It's more the CT scan first because you already have a risk factor, meaning you've had an operation. So, that kind of puts you at a higher risk of developing PE, which could be detrimental. So we go straight into a CT scan diagnosis rather than just going through that algorithm.
And I think this actually brings up a really important point that I was alluding to before. And this could be a whole episode on its own, but it's how often and how much do we test for things that we think are probably not going to be there, but we don't want to miss them. And PE is a perfect example. Is Brodie and James and I will not order CTs only if we think 100% there's a PE. We're going to order a CT if we think there is a 5% chance of a PE because missing that is detrimental. So majority of our scans that we try to do for CT PEs, they're going to be negative, and they should be. And especially in something like surgery, for example, where many people have a high heart rate, many people have chest pain, especially if some surgery up in the belly or the chest. You have to have a really, really low threshold to order a CT to look for PE because you could be missing it.
I mean, and Josh, you probably see a lot of patients that have been admitted to the hospital because they have DVT or PE and can't necessarily go home, or they're at higher risk for things. Like, what are some of the treatments that you're starting?
So we see lots who are admitted to hospital with this. We see, unfortunately, lots who develop them in hospital because being in hospital is a risk factor on its own. So there's a whole range of treatments. And the majority of people who have PEs or DVTs, they don't need to be admitted to hospital. Most of them, you can be put on blood thinners and sent home with appropriate follow-up. Now, treatments really depend on how severe you are coming in with it, what caused it, and we talk about things that are called provoked clots and unprovoked clots. Provoked being you have a major risk factor that we can identify, like you just had surgery, like you just had a flight to Singapore. James, I hope you don't get a DVT.
It's almost like you're wishing for something.
I'm not wishing for anything. I'm still a little upset about the segue, and I'm sorry.
I'm really sorry. I let you down.
And then there's the unprovoked world where you have a clot and we don't know why. And so the upfront treatments, blood thinners, almost universally for everyone, those can be in the form of an injection under the skin or an IV, or in most people, especially if they're not severe, those can be pill blood thinners. And we'll probably talk about those in many other conditions. For the really, really sick people on the other end of the scale, Brodie, this is where you probably come in. There's actually ways to go in and get rid of the clot directly with a procedure. And that's really, really cool. And it's not going to be done in resource limited settings, but they can go in and they can inject blood thinners directly around the clot, or they can actually suck the clot out. And those are for the sickest patients who the clot's affecting the heart, the clot's causing them to go to the ICU, all those kinds of things. So there's a whole range of treatments.
Makes for some crazy pictures when you suck out this giant clot out, because it's like it still is the shape of the blood vessels when it was in the lungs. So it's like pulling out like a Christmas tree. Like, it's like the craziest thing. Anyways.
Yeah. So and then as I was talking about provoked and unprovoked, it dictates how long you're going to be on these blood thinners. So let's say you're doing fine, you're out of the hospital, you're on a blood thinner. This is where a hematologist, a blood doctor, is going to get involved and say, you're provoked DVT, let's do at least 3 months, and then we'll talk about the risks of coming off. Versus if you're an unprovoked, we don't know the cause of it, the risks of it happening again are much higher if you're off blood thinners. So you're going to have a big discussion about risk benefit and whether you actually stay on blood thinners for a long time, lifelong, or not.
Right.
So
I think provoked meaning, there is a reasonable understanding that, something like long flight to Singapore happened and this is why you had it. So if you avoid it, there's a good chance that you're not going to develop this again.
Yeah, and maybe to add on to Josh what you're saying, I'll be honest, like the majority of patients that I'm coming in that have especially like a blood clot in the leg, like a DVT, and a lot of PEs I'm sending home, and they don't need to be admitted as long as their oxygen levels are normal, and I'm not seeing any signs of like unstable vital signs or low blood pressure and stuff like that. So a lot of these patients come in, they have these more on the mild side of symptoms. They get started on blood thin, they get sent home, they get follow up, and that I think is really key, Josh, for that follow up, really to figure out the so what happened and how long do we need to keep you on these treatments for, and maybe talk about blood thinners on its own at another time would be really interesting. But it's also, although we call them blood thinners, there's kind of two different types of medications. We think of like typical blood thinners. These would be things like warfarin or Coumadin, or there's kind of newer medications on the market
like DOACs
that help kind of thin your blood. Probably won't do names. They're probably different in different markets, but apixaban, rivaroxaban, adoxaban, dabigatran, there are all these kind of different ones that are out there. All have their different kind of pros and cons for them. But although we call them blood thinners, your blood is always your clots are always developing clots and dissolving clots, like every seconds sort of thing. And so really how the blood thinners work, it's not only like instantly you take them and they dissolve this blood clot that you have in your lungs or your legs, but it's over the course of the next few weeks, it stops that clot from reforming, right? It kind of helps thin the blood, so it interferes with its clotting process, hence then over time that blood clot kind of like dissolves. But it's a bit different than what we think about another class of medication that we call like thrombolytics, which are truly like clot busting drugs, and these are the drugs that we give when patients are having a stroke or having a heart attack. Yeah, and in more severe cases of people that have like a significant pulmonary embolism, where they are having unstable vital signs, or maybe they've already gone into like a cardiac arrest, for example, and those medications work very quick, but also carry very high risks for things like bleeding then as well. But yeah, just to talk about some of that, because I think sometimes there's like, I'm taking a blood thinner, like the clot will dissolve right away. It's not quite the way that it works.
Right.
And that's honestly the most common question I get is, so what happens to the blood clot while I'm on this blood thinner? And it just like exactly like you said, the body will either chew it up while we prevent another clot or the clot getting bigger with the blood thinner, or the body actually sometimes finds a detour around the clot with other blood vessels. And I mean, some people are left with a clot forever, and most of the time they're not symptomatic with that. Some of the time they are, but the body's really good at getting rid of these things. We just give it a little extra help with these blood thinners.
Yeah, there's a very select patients who do have these kind of chronic embolism in the pulmonary system. And I remember as an intern, I've assisted or observed in some of the surgeries to get rid of them. These are major operations to do that, and these are for only select patients. And surgery isn't really something that we do routinely for patients with blood clots in pulmonary system. But something that we forgot to say is that while all of these is going on, is blood thinning process is going on, the patients may be already quite sick, because their respiratory system is quite compromised. They're having difficulty breathing, delivering oxygen to their important organs, and they may need a trip to intensive care unit, need intubation, mechanical ventilations to help support them, go through all this treatment and keeping their organs alive. It's not just targeting the blood clot, it's that we're taking care of your entire system, making sure that you're staying alive and your organs are healthy.
Yeah, it's a really good point, James. Yeah. And the other thing we haven't really talked about is really more longer term prevention, I guess, right? So besides the whole figuring out was this a provoked or an unprovoked clot and how long you need to be on those blood thinners, but thinking about other things like the so many times mentioned now compression stockings that do actually have good quality evidence of preventing blood clots on things like long flights, but even just encouraging movement. So again, things like James, like you were talking about for patients that have been to the hospital, early physiotherapy, getting people moving. And then again, you look at maybe there's some people that are at such a long-term or kind of chronic high risk for this, that they end up being on some of these blood thinner medications kind of indefinitely for some of that too.
Yeah. And I think a couple quick public service announcements. Number one, these meds don't work if you don't take them. Some of them are once a day, some of them are twice a day. If you don't take them as prescribed, breakthrough clots are much more likely. Number two, they're not perfect medications. You can still get clots while on these. Now, we will do a good thorough checkup to see if there's anything else that's causing the clot, but they're not perfect. And things like compression stockings, things like moving around on James's flight to Singapore, it's actually worked out really well. They're not 100%. So there's nothing in medicine that prevents everything. And this is one of those. It reduces the risk of developing, but it's not perfect.
The other thing that I would add to this is there are some modifiable factors. Like, if you're smoking is a risk factor for developing blood clots. If you're taking hormone replacement therapy, or if you're taking, some sort of form of hormonal therapy that are known to have elevated risk of DVT, those are things that you should talk to the prescribers to make sure that the risks and benefits are well balanced. So those are really important things. And the other thing is, if you do develop these clots and you don't know why, I think it may be and you're of certain age or certain family risk, you should get screened for cancer as well. These may be some of the, unfortunate first signs of cancer diagnosis. So I think it's, another reason to be, vigilant about cancer screening.
Yeah. And James, it's a really good point. And just age-related cancer screening is vitally important. The majority of clots are not from cancer, but you should be getting your colonoscopies and your mammograms and your pap smears and all that kind of stuff.
If you have an unprovoked, blood clot and you don't know why, then and you're of certain age and risk, you should be considered for appropriate cancer screening.
Fine, James, I'll go for my colonoscopy. I get it. Okay.
You're only a few years away.
James, the other thing I think that I really like that you highlighted there, though, is, again, remembering that your birth control pill, your oral contraceptives are hormonal therapy, right? Again, there's so many times I ask people, like, are you taking medications? No. Or it's like, oh, I'm only on the birth control pill. But knowing that, again, like there's great, good reasons to be on oral contraceptives, but just at least having the understanding that, like, that does carry an elevated risk for DVT and PE. So that if you develop symptoms of that, just to raise that, right? Because sometimes it gets missed a little bit. You're like, oh, like this is like, you're young, you're healthy. Like sometimes you can kind of skip over that a little bit. Or sometimes, again, I find it's not uncommon that I ask people if they're on any medications. They say no. And then someone else goes back and asks, like, oh, I take so-and-so for birth control, right? And that does change my perspective for your risk for that. So there is a little bit of like, that kind of self-awareness, only for how it puts your risk in the context of what you're presenting with to the providers that are seeing you there. So
that's awesome. You know what I'm excited for, guys? We're talking about clot busting, but let's talk about myth busting. Heyo, that's how you segue.
Oh, that's a good segue.
Some mytholytics out there.
All right, Josh. You're on a roll, so why don't you go with the myth number one?
Is that what we consider a roll in this podcast?
Oh, God. You put together two sentences together. Right. You're on a roll, buddy.
Oh, that is amazing. All right, so myth number one, only elderly people get blood clots. I think we've talked about it already. Absolutely not true. Yes, some risk factors go up as you get older, but there are many risk factors in the young as well. We just talked about hormonal therapy, for example, plus many others. So definitely not just a disease of the elderly. I'll hand the mic over to maybe Brodie. Brodie, you're next.
My myth. I'd say that pulmonary embolism specifically always kill instantly. Right. Again, a lot of these patients that I'm seeing are coming in with more minor chest pain, some shortness of breath. There's something enough that it's just bothering them, interfering with how they are. Or sometimes it's honestly something they've had that's going on for weeks and they're finally deciding to come in with it. So it's not always like a super dramatic, I'm having this chest pain, I can't breathe, and they collapse. Sometimes it is a bit more of this subacute kind of presentation that's been going on for a little while.
All right, so I want to throw one more. I want to throw one more thing. Sorry, Brodie, you mentioned it, but I just want to highlight it because it's a question I get every day about these. Is I had a stroke. Is it because of a blood clot, or I have a blood clot? Am I going to have a stroke? And you said it already in the podcast, but blood clots in the legs, blood clots in the lungs do not cause strokes outside of very, very rare issues where there's a hole in the heart. So The blood clot usually stops in the lungs, and that's where the problem occurs. So I'll put it out there. There's much more around that, but I just want listeners to know that because it's a question we get all the time. Yeah. And we'll do an episode on stroke. Yeah. Cool.
Time to do takeaways, right? All right. Well, so takeaway number one, I think first is that the clots could happen to everyone. We kind of talked about this already. Blood clots are not just for older individuals. It can happen to anyone. You just have to be aware of what the risk factors are and try to avoid them if you can, and be aware of the signs and symptoms.
Yep. I think takeaway number two, signs and symptoms. We're talking one leg swelling or one arm swelling. Again, arms are very rare, or redness or pain in one leg or one arm. And then in the chest pain, especially when you take a nice deep breath in, trouble breathing out of the ordinary, and then some other things that we're going to look for in hospitals. So keep an eye out for those. These things are still very rare, but especially if you have risk factors, keep an eye out for those symptoms.
Maybe the last takeaway really, maybe this is a shout out to James. Prevention is powerful, man. Please wear your compression stockings for your Singapore flight coming up. Stay hydrated. Go for a walk on those flights. And again, if you've had a clot before, take your medications as prescribed. Well, thank you to our listeners for sticking through us. If you made it this far, if not, then I don't blame you. That's okay.
Yeah.
We had fun.
Yeah.
Take it easy, guys. Have a great flight, James.
Off day for us.
All right.
Thank you.
We'll talk soon. See you guys.
Thank you, listeners.